Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about Mycosis Fungoides. Definition: Mycosis fungoides is not a fungal infection, rather it is a cutaneous T-cell lymphoma with a misleading label. The skin lesions result from the proliferation in the dermis of malignant T lymphocytes, which have a propensity to migrate into the epidermis. The clinical appearance of the lesion depends on the stage of the disease, which may evolve from patch through plaque to nodular ulcerative lesions, reflecting the progressive increase of the cellular infiltrate in the skin. Incidence: Mycosis fungoides is uncommon. In the United States, Mycosis fungoides accounts for less than 1% of all lymphomas and fewer than 200 deaths per year. The disease primarily affects adults, most often those in the older age groups. Note: Mycosis fungoides is a cutaneous T-cell lymphoma, not a fungal infection. History: in the usual case, the eruption slowly evolves over a period of years. It often starts as a non-specific rash, which may be diagnosed as atypical psoriasis or eczema. Parapsoriasis, an uncommon idiopathic disorder characterized by salmon-colored, slightly scaling patches, may be a precursor. With evolution, the lesions become more elevated and indurated. Most patients with Mycosis fungoides have pruritus ranging from mild to severe. Severe pruritus should raise suspicion of extracutaneous, particularly hematogenous involvement. Physical examination: the key to the diagnosis rests with the following features. The lesions are irregular in shape, peculiar in color, often reddish-brown, violaceous or orange, and asymmetric in distribution. The degree of elevation of the lesions depends on the stage of the disease. In the patch stage, the lesions are flat, surmounted by slight scale and sometimes accompanied by epidermal atrophy, which clinically appears as cigarette paper wrinkling of the surface. Other lesions may show poikiloderma, a term used to describe a reticulate pattern of hyperpigmentation, hypopigmentation, and erythema with telangiectasia. In poikiloderma, the epidermis also shows atrophy. As the disease progresses, increased cellular infiltration of the skin occurs, expressed clinically as elevated indurated plaques. These plaques are generally more widespread. In advanced disease, nodules appear and frequently ulcerate. Lymphodenopathy is also often found in more advanced disease and can be reactive or more rarely indicative for malignant infiltration of the lymph node. Sézary syndrome represents a leukemic variant of cutaneous T-cell lymphoma with some features similar to Mycosis fungoides. This syndrome is characterized by total body erythema or erythroderma, lymphodenopathy, and a high number of atypical lymphocytes or Sézary cells in the peripheral circulation. Note: Mycosis fungoides should be suspected in rashes with lesions that are irregular in shape, peculiar in color, and polymorphic, presence of both atrophic patches and thick plaques in a single patient, resistant to therapy for eczema or psoriasis. Mycosis fungoides red to violaceous and brownish, slightly scaling and wrinkled, irregularly shaped patches. Mycosis fungoides, epidermis hyperkeratosis, epidermal atrophy, especially in patch stage, exocytosis of malignant lymphocytes, sometimes in focal collections, portrait microabscesses in dermis, mild to marked infiltrate of mixed inflammation cells, including cerebriform lymphocytes, is present. Mycosis fungoides, irregularly shaped, asymmetric, deep red purple, hyperpigmented, indurated plaques. Mycosis fungoides, ulcerated plaques and tumors on the back. Mycosis fungoides, patch stage, lesions on back of 32-year-old female, and Mycosis fungoides, plaque stage, lesions on abdomen of 65-year-old female. Mycosis fungoides, plaque stage, lesions on back of 50-year-old male, and Mycosis fungoides, tumor stage, lesions on back of 36-year-old male. Differential diagnosis: Mycosis fungoides may appear as parapsoriasis, atypical eczema, or psoriasis. In patients with nodular disease, the malignant tumors may be considered. In patients with Sézary syndrome, the differential diagnosis includes the causes of generalized erythema. Note: Mycosis fungoides should be considered in patients with atypical eczema or psoriasis. The conclusion of differential diagnosis of mycosis fungoides include parapsoriasis, eczema, psoriasis, other forms of cutaneous lymphoma, and erythroderma. Laboratory and biopsy. The most important laboratory test is the skin biopsy. Frequently, multiple biopsies must be performed before a histologic diagnosis can be secured, particularly in patients with early patch stage disease. The most important histologic feature is the presence of portal microabscesses within the epidermis. These represent collections of lymphocytes, many of which are atypical. Atypical lymphocytes are also found in varying numbers in the dermal infiltrate. With high power examination, the nuclei of these lymphocytes are characteristically highly convoluted or cerebriform. In the early stage of the disease, they may be present only in small numbers. In the nodular stage, a dense infiltrate of malignant cell is seen. The malignant cells in mycosis fungoides are derived from a monoclonal proliferation of helper T cells and less commonly suppressor T cells. The T cell receptor gene rearrangement test may be used to determine monoclonality in T cell infiltrates in skin and other tissues. The differentiated helper T cells have specific cell surface receptors that possess specificity that is determined by the arrangement of the receptor gene. A T cell receptor gene rearrangement test detects a population of cells with the same rearrangement, thereby determining monoclonality and finding that is supportive of malignancy. This test has been used as an aid in diagnosing mycosis fungoides in skin, blood, and lymph nodes. False positive results occasionally occur. A new assay termed high-throughput T-cell receptor gene rearrangement has improved sensitivity and specificity for the detection of malignant clones compared to traditional polymerase chain reaction-based assays and may be useful in certain cases. A complete blood cell count with careful examination of the peripheral smear should also be performed when looking for circulating mycosis fungoides cells. If lymph nodes are enlarged, an excisional lymph node biopsy should be performed. Therapy. For disease localized to the skin, external therapy is preferred. Topical steroid, UV light, either UVB or UVA in combination with sorolin or PUVA, nitrogen, mustard gel, bixarotan, and retinoids, imiquimod, and electron beam therapy. Orally administered low-dose methotrexate, retinoid or rexinoid, warinostat or romidipsin, a histone deacetylase inhibitor, and intramuscular interferon alpha have been used in patients with recalcitrant skin disease. In patients with advanced systemic disease, combination immunotherapy, example, retinoid or rexinoid plus interferon alpha, histone deacetylase inhibitors, or vorinostat or intravenous romidipsin, targeted monoclonal antibody therapy, example, brentuximab, vedotin, mogamulizumab, or single-agent chemotherapy is usually used, sometimes in combination with one of the topical modalities. Some patients with Sézary syndrome have also been successfully treated with extracorporeal phytochemotherapy. In this treatment, white blood cells are removed from the patient several hours after sorolin ingestion, externally exposed to UVA, and reinfused into the circulation. Treatments are given on 2 back-to-back days, either monthly or twice monthly. Response rate can be increased by combining this extracorporeal photochemotherapy with bixarotan and or interferon alpha. The conclusion of therapy for mycosis fungoides: initial therapy includes steroids, example, clobetasol cream 0.05% BID, UVB nitrogen mustard gel, compounded topical carmustine, radiotherapy like electron beam, bixarotan, and retinoids, and imiquimod. Alternative therapy include PUA, radiotherapy, total skin electron beam therapy, methotrexate, retinoids, example, isotretinoin or rexinoid, example, bixarotan, pegylated interferon alpha 2A, and extracorporeal photochemotherapy, histone deacetylase inhibitors like warinostat, romidipsin, and targeted monoclonal antibodies like brentuximab, vedotin, mogamulizumab, altimuzumab, and pembrolizumab. Single-agent chemotherapy like paralatrexate, liposomal, doxorubicin, gemcitabine and etiposide, and etc. Course and complications. In most patients, mycosis fungoides is a chronic, smoldering disease with slow progression over many years. Treatment in the early stage can result in complete clearance of the skin lesions, although relapses are common after therapy is discontinued. Systemic involvement develops in advanced disease, usually affecting the lymph nodes first and the internal organs later. Mean survival for patients with systemic involvement is approximately 2 years. Pathogenesis. Mycosis fungoides is a neoplastic disease of helper CD4 plus T cells and less commonly suppressor CD8 plus T cells. Its first manifestation usually appears in the skin. The ongoing debate is whether the process is malignant from the start or whether it begins as a chronic inflammatory condition in which activated T cells eventually undergo malignant transformation. Either way, the end result is a monoclonal proliferation of helper or suppressor T cells in the skin. The initiating events in this disease are not well established. Langerhans cells in the epidermis have been implicated as participating in the initial phases, perhaps themselves stimulated by external factors and in turn interacting with T cells which are subsequently activated. Environmental chemicals have been implicated as a causative factor in some patients, but this has not been well proven. However, for most patients with mycosis fungoides, the underlying origin remains unknown and the pathogenetic pathway is a matter of debate. Note, in mycosis fungoides, there is a monoclonal proliferation of helper CD4 plus or suppressor CD8 plus T cells in their skin. Clinical case. A 52-year-old man presents with a 10-year history of slowly progressive skin lesions on the trunk and proximal limbs. Initially, the lesions were intermittent, mildly pruritic patches, but over time they have become persistent, thicker plaques. He reports that multiple topical treatments, including corticosteroids and antifungals, have given only temporary or minimal improvement. On examination, there are ill-defined erythematous to hyperpigmented patches and plaques with fine staining, distributed mainly over the buttocks, flanks, lower abdomen, and thighs. Bathing suit distribution. Some plaques show poikiloderma atrophy, telangiectasia, and pigmentary chains. No nail chains are present. Mild lymphadenopathy is noted. Skin biopsy shows epidermal tropism or atypical lymphocytes with porphyry microabscesses. What is the most likely diagnosis? A. Psoriasis. B. Parapsoriasis. C. Eczema. D. Erythroderma. And E. Mycosis fungoides. The correct answer, according to our explanations, is mycosis fungoides. K. Diagnostic clues: cutaneous T-cell lymphoma presentation, a chronic, slowly progressive course over years, patch, plaque evolution, bathing suit distribution, pure response to conventional topical therapy, poikiloderma. Histology is epidermal tropism plus porphyry microabscesses and mild lymphadenopathy are all characteristic of mycosis fungoides. While the others are unlikely, psoriasis is a well-demarcated plaques, silvery scale extensor surfaces are usually involved in with auspice sign. Parapsoriasis may mimic early mycosis fungoides but lacks atypical lymphocytes and malignant progression features. Eczema is a spongiotic dermatitis, strong pruritus is present, and usually the response to steroid is very good. Erythroderma is a generalized redness, more than 90% of body surface area, and not patch plaque evolution pattern is present. Okay, this was an explanation about mycosis fungoides. Thank you for your attention.